Or for this last one, we're going to actually combine a couple of these sections because they're relatively short. We're going to look at fertilization, pregnancy, and parturition. For this first part, we're going to talk about fertilization, human chorionic gonadotropin and what it does, the embryonic membranes, the hormones involved in parturition, the changes in breast tissue and prolactin, oxytocin's role, and then the maternal IgG and IgA antibodies in the baby. So fertilization is just the coming together of sperm and egg. This is, again, usually happening in the uterine tubes. Basically, the acrosomal cap, and the zona pellucida cells, which are around the ovum. If we look at what we have the corona radiata and the zona pellucida, which are covering the ovum itself. The acrosome is going to help break away these layers so that the sperm can get in and access the oocyte. So basically, we're going to push our way through the corona radiata and dissolve that zona pellucida right there. Once the sperm gets in, we're actually going to activate the oocyte. We're going to have a calcium release happen that's going to make this zona pellucida impenetrable so that other sperm cannot get in. It's also going to trigger the oocyte to go through meiosis II. So this is what's happening in the very beginning. About 12 hours after the sperm gets in, the nuclear envelope around the ovum disappears, and the chromosomes from the sperm and the egg can actually come together to form the zygote. When it comes to twins, how do we get twins? Monozygotic or identical twins, this is where a single ovum, it splits in that early developmental phase. Dizygotic or fraternal twins are two eggs fertilized by two different sperms. So identical twins are just that, they're identical. They have the exact same genetic material, but dizygotic or fraternal twins are basically just siblings, like normal siblings genetically, that share the womb together. From there, the zygote is going to undergo what's called cleavage. Now, cleavage is going to be where we are dividing but not growing, right? So we're staying the same size. If you notice in this picture, we stay the same size throughout. So this is cleavage. We're going and dividing, right, into 2 cells, to 4 cells, to 8 cells, but you notice all the cells are just getting smaller. That's cleavage. This is going to happen for about 36 hours, about a day and a half after fertilization to get to 8 cells. And then we're going to go through rapid mitosis to form a ball of cells called a morula. This is going to be what gets into the uterus, and then we'll implant. This happens a few days after fertilization. Division will keep happening until we form a blastocyst, which again is this hollow ball of cells where we have an inner mass and an outer like section called the trophoblast. The inner mass is actually what's going to become the fetus. The outer portion, the trophoblast, is going to become part of the placenta. So not every cell here is actually going to be the fetus. Some of it will become placental. And then around day 6 is implantation. This is where we're actually embedding ourselves into the side of the endometrial wall inside the uterus. We have enzymes that allow us to kind of eat our way into the endometrium and kind of nestle in. And so it's important to note that the term pregnancy refers to after implantation. Everything here is not pregnancy, right? That is just fertilization, but it's not pregnancy. And so this is why something like Plan B can function. Because if you've ever noticed, Plan B can happen up to about 3 days. It's good for about up to 3 days after unprotected sex or failure of another birth control method. And the reason being is we're just trying to break this down, prevent this from getting all the way in here. After this, especially if that ovum implants, if that zygote implants, something like Plan B cannot stop this from, it cannot destroy this. So things like birth control pills, things like Plan B or emergency contraception, they will work up to about this point, and then once we're over here, they do not function anymore. So they cannot terminate a pregnancy because, again, this is what we consider pregnant. This is not what we consider pregnant. And so then if we do have implantation occur, the corpus luteum is going to stay. until the placenta takes over. So the corpus luteum will stay a lot longer until the placenta is developed enough to produce its own estrogen and progesterone to maintain that inner lining and the fetus, as well as to help with the changes in breast development and milk production. And so during this time, the corpus luteum, we're going to be maintained by what's called human chorionic gonadotropin. And so as the placenta develops, it's going to release HCG to maintain that corpus luteum. It's also going to secrete estrogen and progesterone to support the pregnancy overall. So the blastocyst will produce HCG. It'll keep the corpus luteum going. And then the corpus luteum will kind of take a back seat once the placenta is really like rooted in. HCG is also the basis of a pregnancy test. So if you have ever had a pregnancy test or have known someone who's taken a pregnancy test, you know there's like those dipsticks where there's either ones where you urinate into a cup and then use a dipstick into it, or the at-home pregnancy test where a person will urinate onto the stick itself. And what it's looking for, how it works, is the pregnancy test is detecting HCG. And because this is something we only see if someone is actually pregnant, right? So this will trigger, this will happen. The pregnancy test will detect HCG. Basically, the HCG binds to that line of there's basically antibodies made for HCG imprinted on that test. And as the urine passes through, any HCG that is present, if it's there, will bind to those antibodies, and that's what gives you the blue line, right? It's a really simple, easy test that we use to detect things like that. It's just a simple little assay. But we're not getting all into how pregnancy tests work. We just want to talk about now how the embryonic membranes are going to develop, because it's not just a placenta just on its own. We have bits and pieces, and they all perform different jobs. So let's go ahead and talk about how as the blastocyst develops, the endometrium is going to change into a decidua basalis. This is going to join together with the chorion to form the placenta. So we have, if we look at the placenta, we have this amniotic sac containing amniotic fluid, which is called the amnion. We have the chorion going around that, right? And then we have the all contained, right, as the placenta. The chorion, right, again, is surrounding the developing embryo. It has a fluid-filled space between that becomes the amniotic sac, right? The amniotic sac with amniotic fluid is coming from basically secretions, as well as urine and any old cells. And this is the basis of something like an amniocentesis, where we take some of that fluid and we can test some of those sloughed off cells to check for things like genetic mutations. We also have connection with the bloodstream between mom and baby, but it's not a direct connection. Rather, we're going to use diffusion between the blood vessels from mom and the blood vessels from the fetus. So umbilical arteries, right? If we look at the umbilical cord, umbilical arteries are going to be here in blue, umbilical veins in red. It's backwards from what we're used to. But that makes sense because we're not using the lungs to oxygenate. We're using mom's blood. We're using the placenta to oxygenate. So umbilical arteries are going to run away from the fetus into the placenta. Umbilical veins, which have already been oxygenated, are running back from the placenta to the fetus towards the heart. But if we look at what's going on, we basically have these tree-like structures, right? Forming from the fetus's blood vessels, right, on the fetal side. And then on the mother's side, we have these veins that kind of create these big long stalks, but these arteries are almost forming these pillows around these trees, right? And so we notice that the maternal and the fetal blood do not actually directly connect. They are separated by some cell layers, but it's very, very minute. It's only 2 cell layers thick. Because we're going to use diffusion to move oxygen and nutrients. Oxygen nutrients will diffuse from mom's blood to the baby's blood, and then carbon dioxide and waste will go from the baby's blood to the maternal blood. Right, but look at how that is structured. It is not what you would think of. You would think of a direct connection, but it is not a direct connection at all. Now, parturition, right, this is where we're getting into birth. So this is where we are forcing that fetus out using contractions. Basically, the fetus has gotten, an eviction notice. And so the person is going to give birth to that baby. This is in response to oxytocin and prostaglandins. These two are going to stimulate calcium's release, which is going to stimulate muscle contraction. We already know how calcium plays in with muscle contraction. The corticotropin releasing hormone from the placenta is also going to help initiate labor. As it goes up, labor will be triggered. And CRH is also going to stimulate ACTH from the pituitary, which is going to stimulate cortisol from the adrenal glands for both the mom and the baby. And cortisol is going to help with producing the surfactant in the fetal lungs, because up until this point, the fetus has not needed to breathe oxygen. It doesn't breathe air yet. But as soon as it's born, it's going to need to, and the lungs are going to need to be able to open and not collapse in on themselves. So cortisol is going to play a role in helping those lungs, be ready for when the baby's born and it needs to breathe air. So if we look at what's happening, right, estrogen from the ovaries is going to induce oxytocin. Oxytocin is going to stimulate contractions. It's going to stimulate the placenta to make prostaglandins, which stimulates more contractions. So we have a positive feedback loop. And this feedback loop is going to continue until that fetus is born. And the reason why this is happening is there are stretch receptors on that cervix that are detecting the baby's head pushing on it. That's going to stimulate oxytocin, which stimulates the contractions. The contractions then happen, which pushes that baby's head on that cervix more, stretching those receptors, stretch receptors more, triggering more oxytocin. And so you can see where we're going, like it's a runaway train. Of course, once the baby is born, those stretch receptors are no longer triggered, which then stops the positive feedback loop. In the mammary glands, some things that change, breast tissue will change. So cortisol, thyroxine, insulin, these are going to make the mammary glands more sensitive to the rising progesterone and estrogen levels. Progesterone will stimulate the alveoli growth, and estradiol will stimulate tubule and duct growth. So this is going to stimulate more the growth of the tissues that are going to be responsible for making milk. And then when it comes to actual lactation, prolactin is going to stimulate the production of the milk, and oxytocin, which will stimulate the contraction of lactiferous ducts. And like I mentioned before, the suckling from the infant is going to release that oxytocin to promote this process. Now, breastfeeding and immunity have a link. There are ways for the mother's body to help protect the infant. Since the infant's just born, its immune system is very naive and it doesn't know how to protect itself against specific pathogens yet. However, breastfeeding, some of these antibodies can pass over from the mom to the fetus before birth. So IgG, these can transmit from mom to child. And then IgA, this is going to be what's passed through breast milk. So we have a couple ways to protect that infant with its very naive immune system. So IgG antibodies go from mom to baby before birth, and then IgA antibodies go through the breast milk after birth. All right, last thing we're going to do, we're going to roll these together so that we don't have super short videos, but we're going to get into clinical applications. So this is going to link with pregnancy really well, because we're going to talk about how birth control works, as well as other methods, including hormonal birth control. We'll talk about changes in the reproductive tract that are related to age and some common disorders for both male and female tracts. And then, of course, we got to talk about STIs. I'm going to warn you, we are going to have photos at the very end of what STIs look like. So just keep that in mind. And I'll make sure to preface that so that you're aware that we will see those photos. So contraception, aka birth control, are basically just designed to help limit how many children a person produces. And this is to prevent conception, right? Contraceptive. So this is to prevent someone from getting pregnant. Of course, the only way that is 100% reliable is abstinence. I have to say that because it's true. However, it is not realistic to rely on abstinence to never get pregnant, because to rely on abstinence means you're never having sex, ever, ever. So nobody, I should say very few people choose to be abstinent forever. And so, or at least until they're no longer reproductively viable. So let's talk about the things that we can actually do that are more realistic, right? Because again, abstinence, sure. Is it 100%? Yes. Is it fun? No. So let's talk about some things people can actually do that are more realistic. And so there's a couple things that involve like the barrier methods, surgical sterilization, hormonal methods, and what's called periodic abstinence. So if we look at the table here, we have a couple different types. We have the complete abstinence, which again, you're never having sex, and so you are not having that type of intercourse, and so you can't get pregnant at all. Surgical sterilization is very, very, very good. You have just a fraction of a % failure rate with both tubal ligation and vasectomy. So sterilization, while it's not perfect, it's very near perfect. We're talking again a 0.5% chance of getting pregnant or less, right, with surgical sterilization. The hormonal methods like oral contraceptions, this is going to include things like extended cycle pills, combined pills, mini pills. These are all basically just, again, the birth control pill. There's a lot of different types. Some of them are a combined progesterone estrogen pill. Some of them are just progesterone. These, again, they're very good. The perfect use puts them at about 0.3% failure rates. However, with regular, what we'd consider typical use, this is how most people end up doing it, we see about a 1 to 2% chance at failure. With non-oral contraceptions, this is going to include things like hormone injections, so things like the Depo shot, there's contraceptive skin patches, the Nuva ring, things like that are going to be included. I'll talk about the regular use ones, which are like the patch, the ring, and injections. These ones are going to be very similar to the hormonal contraceptions. So they're all hormonal, but they're the non-oral ones. So these are going to be very similar rates of failure as the non-oral or the oral versions. Emergency contraception, which is going to be things like Plan B, has about a 25% failure rate. So, because this is what you're taking after you've already had unprotected sex, or after your other method has noticeably failed, like for example, as if like a condom broke. So it's not perfect, but it has a 75% chance of helping you prevent pregnancy. The IUDs, or the intrauterine device, is a little bit less protective, but still, less than 1% chance of failure. Spermicides alone, so this is you're just using a spermicide, you're using nothing else to prevent pregnancy. Perfect use is a 15% chance of failure, and with typical use is almost a 30% chance of failure. When we look at condoms, these are going to be barrier methods, so there's male and female condoms, diaphragms, and cervical caps. We see that their typical use, the failure rate is around 15 to 20%. And then periodic abstinence, this is what's called the rhythm method, or symptothermal method. Rhythm method is the one that's probably better known, where someone is basically being very in tune with their own cycle. So they're looking at things like their own discharge. They're looking at what time of the month it is, and trying to plan so that they don't have sex around when they are fertile, like in their fertile window, as they'll call it. That has about a 25% failure rate, though. And then no method, the failure rate is about 85%. So no matter what, any of these options are better than not doing anything to prevent pregnancy, because they all are at about a 25%, we'll say a 30% chance and below of failing, whereas no method is an 85% chance of failing. So really important that if you are trying to avoid getting pregnant, that you do something. Usually the hormonal methods and the sterilization methods are the most accurate, the most reliable. So let's talk about surgical sterilization. Surgical sterilization, again, this is just a vasectomy, which we already talked about, preventing sperm from getting through. We see we've actually cut, right? We've actually cut the vas deferens. They've severed completely, and so any sperm produced here cannot get up here and cannot become part of the ejaculate. Tubal ligation is very similar. It's just doing the same thing but to the oviducts. But you notice there's a couple things we can do there. We can band them, we can cauterize them, or we can cut and tie them, right? So a couple different options with tubal ligation. It's important to note, if you are considering sterilization, a vasectomy is much easier to complete because it is a smaller procedure and less invasive. A vasectomy typically is going to be a very quick procedure, whereas a tubal ligation requires abdominal surgery. So if you and a partner are considering sterilization, you may want to discuss a vasectomy first, because the vasectomy is going to be an easier procedure to handle versus tubal ligation. Usually a lot of people, what they'll do is if they're looking for a tubal ligation, they'll do it after getting a C-section. If they had to give birth via C-section, they'll say, hey, since you're already in there, go ahead and tie my tubes while you're at it, right? And that way we don't have to have a second procedure to do that. With the hormonal-based ones, these are designed to prevent pregnancy because they stop ovulation. So if you don't ovulate, you can't get pregnant. And so there's a couple things. We have the combined oral contraceptive pills. These are going to have estrogen and progesterone, because these are going to inhibit luteinizing and follicle stimulating hormone needed. We have the vaginal ring, or the Nuva ring. This is going to have progesterone and estrogens. Same thing, same end product. Mini pills are going to have progesterone only. This is going to stimulate or inhibit luteinizing hormone for ovulation. And then again, the morning after pill, or Plan B, also called emergency contraception, is going to be levonorgestrel. This is a form of progesterol. Again, it can be taken up to 72 hours after pregnancy, but after those 72 hours, you really can't rely on it. Now, this can prevent pregnancy because it can alter the endometrium and prevent fertilization and prevent implantation. But after pregnancy is already achieved, the morning after pill cannot do anything. So the morning after pill and Plan B are not going to cause an abortion. They're not going to stop a pregnancy that has already occurred. It can only prevent a pregnancy that has not happened yet. And that's why they have a higher failure rate compared to the hormonal pills we talked about on the upper part of the slide. Other things like the different devices that we can use, so like an IUD or an intrauterine device, this is inserted into the uterus by a medical professional. There are hormonal and non-hormonal ones. I'll talk about the non-hormonal, since the hormonal ones, it's all the same kind of basic stuff, you know, but the hormonal one uses copper, and these copper ions are toxic to sperm, which means sperm cannot actually get in and fertilize an egg because the sperm are killed before they ever get to the fallopian tube. There's also a fallopian implant. This is a little metal coil that is going to basically cause scarring and prevent fertilization from happening, so nothing can get through. It just scars it up. Basically, it scars up the fallopian tube so no egg can ever get through. Barrier methods, these are going to protect against conception. This is also the only method that can protect you against STIs. It's important to note the birth control pill cannot stop you from getting an STI, since that's a totally different thing, but barrier methods can protect you against both. Again, there's things like cervical caps, diaphragms, female and male condoms. Most people are most familiar with a male condom, which is the condom that goes over the penis and will serve as a barrier between the penis and the vagina entirely. But there's also the female condom, which is like this. There is the diaphragm, which is this little structure that fits over the top of the cervix, right? And then the barrier method, right? Again, cervical cap, which will go over the cervix and prevent sperm from getting in. So we have like right over the cervix, we have something that blocks the entire cervical opening area, right? We have then the female condom, which is placed inside the female, and it will basically protect against the entire vaginal canal. And then the male condom, which again is probably the most popular, is going to be over the penis. So let's go ahead and talk about some changes that happen through life. So we have puberty. This is when we go through secondary sexual development, so sexual maturity is achieved here. Basically, in puberty, we have females developing the reproductive cycle, so they start getting their period, so the menarche, which is the first menses, all the way to menopause, which is the last one. The first period usually happens around 10 to 16 years old. It can vary, it can really vary. Most people get it probably about the time they're a teenager. And this is they're gonna go through their cycle all the way until they get to about their 40s or 50s. This is where we enter into perimenopause. This is where the ovaries are less responsive to follicle stimulating and luteinizing hormone. Fertility starts to go down, but it's not zero. And progesterone and estrogen production is going down too. Then menopause, which is again 45 to 55. After you've gone through menopause, there is no fertility left. This can also have a lot of side effects, including hot flashes, where someone feels like they're really, really hot. That can lead to sweating. Vaginal dryness can occur. Their body is not able to self-lubricate as well. It can also lead to emotional changes, so things like depression, emotional fluctuation, so mood swings, weight gain. Because there is a change in hormone levels, this can cause a change in things like weight gain. There's an increased risk of osteoporosis, because remember that estrogen and whatnot is going to help maintain bone density. There's also an increased risk for things like breast and uterine cancers. In males, they do have a decline in reproductive function as well. However, it's not as pronounced as the female side of things. Usually males will retain some reproductive capacity all the way till they're old, right? 80s, 90s years old. So this is something, we don't see the same decline, but we do see decreasing levels of testosterone, which will lead to like muscle mass disappearing, sexual drive will drop, and then their sperm production will also drop. So while they're still technically fertile, they're not going to be as fertile as when they were younger. And then a lot of times older men will have issues with their prostate. Prostate disorders become really common with older age. Usually it's benign. Basically the prostate just is enlarged. It can be cancerous, but a lot of cases it's not. It's just an oversized prostate that makes it hard to like urinate fully. If we look at disorders in the male, we have things like testicular cancer. This is going to be cancer that originates in sperm-producing cells. This is one of the most common cancers in young men. So it is something important to check for. Everyone with testes should be regularly checking once a month, just making sure that the testes feel smooth, because the first sign, the earliest sign you can detect is usually a painful mass in the testes, and you can feel that lump, you can feel that mass with your own hands in a lot of cases. And so it's really important for someone with testes to do this monthly check to make sure the testes still feel smooth. There's also prostate disorders like the prostate cancer. This is the leading cause of cancer deaths in males in the US, and benign hyperplastic prostate, which again is an enlarged prostate, like you see here. So this is a prostate that is enlarged. It can actually kind of block urine flow from the bladder. So someone with an enlarged prostate may feel the urge to go urinate, but they can't fully empty their bladder. So they have to urinate very often. So having to urinate very often is a common sign that there's an issue with the prostate, and it means you should go get it checked out, right? So if you are someone with a prostate, if you are someone with testes and whatnot, and you notice that you're urinating more often than you used to, it's really important to go get that checked. On the female side of things, we have endometriosis. This is where that inner lining of the uterus, the endometrial layer, can grow outside of the uterus. This can lead to a lot of pain, or whether it's unusual, like that it's a lot of pain, or it's pain at different times where they shouldn't experience any sort of cramps. The only treatment for it is to like ablate that tissue, so surgery to go in and destroy the endometrial tissue that's growing outside of the uterus, or a hysterectomy. Breast cancer, very common cancer in U.S. women. It's most common after menopause, and there are a few genes that increase your risk, namely the BRCA1 and BRCA2 genes that put you at an increased risk. This is why people typically get mammograms when they're around age 40s or so. But if you have these genes, if you have these risk factors, genetically speaking, you should be getting checked very early on. Ovarian cancer is also very common in females. This is going to be cancer of the ovaries. The risk factors include age, race, so people who are older, people who are white, people who have a family history, who have never had children, or their first pregnancy was after age of 30, are at a higher risk of ovarian cancer. A high fat, low fiber diet, and then exposure to things like talc, asbestos, things of that nature. Ovarian cancer also does go up with the risk if you have the BRCA1 gene as well. So not only if you have BRCA1 should you be getting checked for breast cancer, you should also be on top of ovarian cancer as well. Cervical cancer, this is going to start with cervical dysplasia. Basically, a pap smear can detect this in the earliest stages, where we look for cellular changes from that pap. It is caused by human papillomavirus, or HPV, which does have a vaccine, meaning you can be vaccinated and prevent most of your risk of developing cervical cancer. Vulvovaginal candidiasis, or candidiasis, this is what's called a yeast infection. This is an overgrowth of the fungus Candida albicans. This is a normal microorganism found in the vagina, but because of certain factors, it has overgrown. This can lead to itching, a thick yellow cheesy discharge, and pain. It's something that can be treated over the counter. There are plenty of treatments like Monistat and whatnot that can be used for this. And it's really, really common. It's a really, really common issue for people with vaginas. And then we get to the STIs, and we're going to talk about some here. I will warn you, there will be some pictures in a little bit. So let's start with chlamydia. Chlamydia is caused by a bacterium called Chlamydia trachomatis. This is the most common STI. It also can be very, very damaging. Usually you don't realize you're infected because you have no symptoms, but males will usually develop urethritis, and in females this urethritis can spread all the way up to uterine tubes. This is called PID, or pelvic inflammatory disease. And PID is a serious problem because it can cause you to lose fertility. It's not something you want to have. So while there are symptoms like changes in discharge and pain during urination and all that kind of stuff, a lot of people don't have symptoms. And so you could lose your fertility and not even realize it because of chlamydia. Gonorrhea is caused by another bacterium called Neisseria gonorrhoeae. This is going to cause inflammation in the urethra with pus and pain during urination for males. In females, this can happen anywhere in the urethra, vagina, cervix, usually a discharge too. However, a lot of times, same thing, no symptoms until it's gotten really, really bad, including pelvic inflammatory disease. Both of these are bacterial, meaning you can take antibiotics and get cured of these. So these are not end-all be-all sexually transmitted infections. They are things that are really common, and it's also easy to test for and easy to treat. Again, the treatment usually it just involves a round of antibiotics of some sort. Syphilis is another bacterial one caused by Treponema pallidum. This is a really old disease. We've known about syphilis for a long time. It can be through sexual contact, but also the exchange of blood from mom to fetus. It is a weirder disease, though, because of several stages, including primary, secondary, latent, and tertiary. And it's weird because you'll have like this painless open sore called a chancre. or a canker, and then you over time develop a rash, fever, aches, and then you get to systemic infection where it starts hurting like your cardiovascular system and whatnot. This is happening over the course of like the sore will be over like the course of weeks, the rash, fever, aches will be over the course of months, and then the systemic infection is over the course of years. But it's weird because in between each of those stages, you'll have a break where you feel nothing. There's no problems. So it can be a little hard to connect the dots to know that, oh, this person's infected with syphilis. But again, it's bacterial, and so we have treatments for this, and usually it just means, again, a round of antibiotics. But then we get to the ones that are viral. And so viral ones, if you have them, you generally are stuck with them. Things like genital herpes, this is caused by herpes simplex virus 2, sometimes also caused by HSV1 as well. But in either case, herpes in the genital region is going to it's going to show as painful blisters, whether that's on the penis or on the vulva or vagina for females, or the penis for males. These blisters will come and go, but the virus is there forever, typically. So basically what you'll hear about outbreaks, like someone has an outbreak of herpes, they have the active sores, but in a lot of cases, like those will come and go, and usually there are triggers like stress or whatever that can cause it to have an outbreak. There are medications that people can take to help. When a person has open blisters, it is very easy to transmit. They can transmit at any point, but it's easier to transmit when that person has open, active sores. It is highly stigmatized because it is for life. However, it's important to note people who have genital herpes generally live a long, happy life. There really isn't any problems besides the discomfort that it can cause when an outbreak occurs, but generally speaking, it's very similar to like how chickenpox and shingles are related, where you can have chickenpox and then shingles later because the herpes virus, like the chickenpox virus, is just hanging out in your body long term. Genital warts is another one that will cause bumps on the genital areas. This is caused by HPV. It's important to note there are a lot of different strains of HPV. Some of them are more related to genital warts and others more related to cancer. The vaccine for HPV protects you against strains related to cancer. It doesn't necessarily prevent you from getting genital warts, so you should still be careful when you are engaging in sexual intercourse, right? Even if you've gotten vaccinated against HPV, because again, HPV has a lot of different variations, a lot of different versions. The vaccine is protecting you against the most cancerous causing ones, not necessarily the ones that cause genital warts. So next page, we're going to see some photos, right? So this is what genital warts look like. Again, it looks like just like almost like skin tags, like there's an overgrowth on the skin. We see with genital herpes, there are like sores that are a little bit weepy that we don't see with genital warts. And then syphilis, this is like systemic. We're seeing actual body sores elsewhere besides the genitalia. And of course, there are plenty of others out there. This is just the quick and short list, right, versus the long list of all the different STIs that are out there.